Good. So this lab report belongs to a 3-year-old with Burkitt's lymphoma who just had chemotherapy. I'm not going to talk about Burkitt's lymphoma, but I'm going to tell you that. Good. So let's just look at the lab report. You see, you have a child with an HB of 9. It just tells you that the child has anemia, isn't it? Yeah. And for someone with Burkitt's lymphoma, are you surprised he has anemia? Are you surprised he has anemia? Please. Hello.
Hello, Doc.
I'm asking a question. Answer me.
No, Doc.
Yeah, they are not surprised he has anemia. It is probably an anemia of what? Chronic disease, isn't it? Because Burkitt's lymphoma is a cancerous lesion. Good. But what we don't understand is why you should have an elevated creatinine, a low calcium, an elevated phosphate, and then the albumin that we have. Okay, so let's see. What is the most likely diagnosis here? Yes. You said it's tumor lysis syndrome, isn't it? The diagnosis this child has is tumor lysis syndrome. So let's go to the whiteboard. We'll explain that soon. Okay? Augustina?
Yes, please.
What is your local name?
Akos.
Akos, okay. Oh no, there's one Akusia here, so I can't call you Akos. All right, that's fine. Now listen. When should you suspect someone of having tumor lysis syndrome? When should you suspect someone of having tumor lysis syndrome? I want to begin by saying that tumor lysis syndrome is one of the acute oncologic emergencies, okay? When someone has a cancer, he's at risk of having a lot of emergencies. And one of them is tumor lysis syndrome. Sometimes can have febrile neutropenia and all that, okay? So it is an oncologic emergency. It means that you suspect tumor lysis syndrome whenever, one, the patient has cancer. And not just any cancer, especially lymphomas. Not just any cancer. Solid cancers of solid organs, especially lymphoma. Okay? And you should suspect tumor lysis syndrome in a patient with lymphoma when the patient, it can happen before, okay? It can happen before chemotherapy. No, cancer patients always undergo chemotherapy and all. Or less commonly after chemotherapy. After chemo. Now, whenever you have someone who has a cancer, okay, and then even before chemotherapy, he starts giving you signs of tumor lysis syndrome, it means that the cancer burden was too great. And so the cells started breaking spontaneously. The cells started lysing. The tumor started lysing because there were a lot of cancerous cells in the body. Do you understand?
Yes, Doc.
But typically, there have been yet to be someone who has a cancer like lymphoma, had chemotherapy, and then started. So whenever someone has lymphoma or a cancer and then undergoes chemotherapy, and then you are told that a few hours after undergoing chemotherapy, the patient has features of AKI. So suspect tumor lysis syndrome. Suspect tumor lysis syndrome in a patient. I'm telling you this because my genius had this question in medical school. The patient had a cancer, so sometimes it may not be lymphoma. The patient had cancer and then underwent chemotherapy. And then a few hours or days after chemotherapy, he was found to have features of AKI. What is the diagnosis? The answer is tumor lysis syndrome. To suspect any patient of tumor lysis syndrome, if that patient has a cancer, underwent chemotherapy, and after a brief period, an acute period, he starts having AKI. And you know, clinically, AKI would present as what? Either decreased urine output or what? Anuria. No urine is coming out. Do you understand?
Yes.
Thank you. So now listen. You have a cell. First of all, I should tell you that the electrolyte imbalances in tumor lysis syndrome, what I used to remember right from school, when I was in school, was PUKCA. I just separate the calcium from them because these guys would go high. PUKCA, PUKCA. P stands for phosphate, so there will be hyperphosphatemia. So you may find it in MCQ anywhere. U stands for uric acid, so hyperuricemia. K stands for potassium, hyperkalemia. Then there will be what? Hypocalcemia. Why? Now, the cell, intracellularly, you know that the cell is a bag of potassium. Phosphate. Do you remember? I posted a fluid and electrolytes lecture. Do you remember? So, whenever the cell breaks down, all its content comes out. That is why the patient would have hyperkalemia. I mean, you are saying it's tumor lysis, and then cancers are what? A lot. They are growing out of what? Regulation. And so when they lyse, they just pour their content like that. And that would be what? Hyperphosphatemia. So the reason why the patient would have hyperphosphatemia and hyperkalemia is that what? Because of the lysis, there is necrosis of the cancerous cells, and so intracellular contents are what? Released. And that would cause the hyperkalemia and hyperphosphatemia. Then the cells also have nucleus, okay, which contains nucleic acids, deoxyribonucleic acid, DNA. So when the DNA is broken down, tumors have a lot of them, okay? You have purines and all that. They can be what? Converted to what? Uric acid. So the hyperuricemia is as a result of what? Nucleic acid metabolism, which has also gotten into circulation because of what? The lysis. Are you getting me? Silent majority.
Yes, though.
Yo. Now, phosphate is a calcium binder. Phosphate is a calcium binder. So because of that, because there's hyperphosphatemia, some of them will bind to the calcium in circulation. And that will further what? That will decrease the calcium. That is why the patient has hypocalcemia. Let me ask you, Which acid-base disorder do you think this patient would have?
Metabolic acidosis.
Why?
Doc, you mentioned that hyperkalemia is most of the time associated with metabolic acidosis.
So hyperkalemia is associated with what? Acidosis. Hyperkalemia is associated with acidosis. That is why, as part of the management of hyperkalemia, sometimes we give sodium bicarbonate, which is a base, because we know that if you're able to make the blood alkaline, we may control the hyperkalemia a bit. Okay, hyperkalemia is associated with acidosis. Okay, and of course, you would expect to find a high LDH because LDH is found in a lot of cells, isn't it? Lactate dehydrogenase. So you may find out an elevated LDH. Have I communicated?
Yes, Doc.
Thank you. So this patient has tumor lysis syndrome. How do you think we can prevent this? When the patient is going to have the chemotherapy, you know, the reason why the patient had the renal failure actually is because of deposition of uric acid crystals, uric acid, and then calcium phosphate crystals. So it caused acute tubular necrosis, okay? And that is what will cause the AKI. Is that okay?
Yes, Doc.
Yaira, do you understand? Yaira?
Yes, Doc.
Okay. So how could this have been prevented? First, when the patient is going to have the chemo, you make sure that the patient is not dehydrated. So before the chemo, the patient should be well hydrated. IV fluids now, we have to keep the patient very, very hydrated so that even when the tumors, you know, because you see, the chemotherapy is going to work on the tumor and then break it down. Even if their contents are released because of a relatively dilute liquid environment, the kidneys will not feel that effect. In fact, one of the things that will even contribute to the hyperkalemia is because of what? AKI. So it is true that the hyperkalemia is coming from what? The lysed cells. But the kidneys are responsible for regulating potassium. That is why hyperkalemia is a complication of CKD or AKI. Now, the cells are lysed, potassium is released, the kidneys have also been blocked by the calcium phosphate and the uric acid. So you know one way to protect your kidney is always by drinking a lot of water, lots of water, lots of water. So before the patient goes to chemotherapy, the patient needs to be well hydrated before the chemotherapy. That is one of the ways to prevent this, okay? Another thing is that before the patient goes to chemotherapy, we may have to give the patient hypouricemic drugs, okay? Before chemotherapy, prophylactically, we can give drugs which have the ability to what? Reduce uric acid. Like, yes, commonly, what do you know of?
Allopurinol.
Allopurinol. Allopurinol. Allopurinol. If you don't have allopurinol, what can you give? Or aside allopurinol, what can you give? Ras what? Ras what? Rasburicase. So uric acid lowering drugs like allopurinol, rasburicase, febuxostat. And some American and high falutinol, trotol, and then make sure you know them. If I was asked, I don't see any reason why they will say, let's forgive you. Allopurinol RAPS uricase, febuxostat. So these are the two main. There is also another way, but that one is controversial, so I don't want to mention it. Or let me mention it so that you just keep it in case you find it in MCQs, and then the other one looks so off, you may be able to. One of the ways they are saying that we should control this is by alkalinizing the urine, make the urine alkaline. So urine alkalinization, so that you don't make calcium phosphate stones form in the urine, and that will further worsen the AKI. But it is controversial. But kindly note that it was one of the things that was suggested. So first, the core, when you're asked, what is the core method of preventing this? Please always mention IV fluids, adequate IV fluids first before you mention the hypouricemic agents, and then end there. But if you are asked to give more, you say, although controversial, urine alkalinization has also been suggested. Have I communicated?
Yes, Doc.
So when you are suspecting a patient with tumor lysis syndrome, the investigations of course, the patient would come with what? Complaints that he can't urinate. So that's what to make you suggest, suspect AKI. So oliguria. Once the patient has oliguria, you have to pass a catheter. Pass a catheter. One of the ways to diagnose AKI is to pass a catheter and monitor the urine output. Monitor the urine output over 6 hours. One of the ways of diagnosing AKI, there is a criteria called the KDIGO criteria. I'm not going to bore you with that now, but please get this principle. Pass a catheter, a urethral catheter, and then monitor the urine output over 6 hours. And if over 6 hours, the patient produces less than what we know, 0.5 ml per kg per hour, then the patient most likely has an AKI. Other investigations you should request for is what? Blood, urea, electrolytes, and creatinine. And so here, you will find out that the patient... Tina?
Yes.
Yeah, your hand is raised.
Please. I want to ask a question.
Go ahead.
Yes. I want to ask a question regarding the hydration. You said we should ensure adequate hydration. I wanted to understand, like, the IV fluids, do you give it to the basic adequate level, or you just have to give excess? And
No.
how much the
maintenance?
hydration is?
Give the maintenance.
We just give them it. Okay.
Yeah.
Okay.
And if so the point is that assess the patient's level of dehydration. I will send the fluid and electrolyte lecture to you soon. When I have a patient going to do chemotherapy, assess his level of hydration. If you think that he is not dehydrated, let's say he is scheduled for chemo tomorrow, you think that you have to assess his level of dehydration and make sure that he is very well dehydrated. When I say well hydrated, I don't mean excess or no, or else you might put him into fluid overload. Already he's anemic. You might stress the heart. So make sure that he's well hydrated. Make sure he is not in any dehydration. Give him his maintenance. If he can't drink water, hydrate him. And whilst you're hydrating him, you have to make sure that you keep a strict input and output chart to ensure that whatever fluid you are giving, it's coming out. Because remember that the tumor lysis syndrome can also occur before chemotherapy. Do you understand? Tina, do you understand? Hello?
Yes, please. I do. Thank you so much.
So if you assess him and he's dehydrated, correct the deficit. Correct the deficit. Now, if he can't drink, give him his maintenance before the chemo. Now, if you do the blood, urea, electrolytes, and creatinine, you will find out that the electrolytes may show what? Hyperkalemia. So what investigations would you do? Hyperkalemia, you may have what? Elevated urea and creatinine. Elevated urea, creatinine, and low bicarbonate because of the acidosis. Then what else would you do? You want to do serum calcium, and then serum phosphate levels. And whenever you request for serum calcium, if the lab has a good GCS, they will add albumin. But a lab, no GCS, no format. They will just bring the calcium to you. You get it? They will add albumin. What else can you request for? You can also request for serum uric acid level. You can request for serum LDH. Are you following me?
Yes, sir. Yes.
So how do you manage them? You sing the song. Tumor lysis syndrome is an oncologic emergency. And so I quickly have to admit the patient, call for help, and assign roles to those I have called. Someone would have to bring an oxygen cylinder. Someone would have to set the tray for IV line. Someone would have to bring the ECG machine. Someone would have to bring sample bottles. That is assigning the roles. Then you do a quick primary survey assessing airway, breathing, and then circulation, and appropriately manage any abnormality you've noted, including starting supplemental oxygen. If the patient's saturation on room air is less than 94%. Then quick IV hydration, but you are not so eager because remember that the patient is in AKI. So you have to hydrate the patient to be able to flush the uric acid out of the renal tubes. So quick IV hydration with what? With catheterization to monitor. So adequate IV hydration with catheterization, urethral catheterization to monitor the urine output. Then uric acid lowering what? Drugs like allopurinol, the buxostat, perhaps uricase and all that. Then you manage the complications. And of all the complications, which one is very, very dicey?
Hyperkalemia.
Hyperkalemia, because high potassium levels can stop the heart suddenly, because potassium can cause hyperkalemia-induced cardiac arrest. It can cause arrhythmia. So you have to what? Stabilize the heart. First, the arms of hyperkalemia management. Now, Suma, take me through. How do you manage hyperkalemia? What are the arms of hyperkalemia management? Just tell me the principles. Yes. 1, go.
You stabilize the heart.
Your first duty as an emergency on call is to stabilize the heart because of hyperkalemia-induced cardiac arrest. What is your next arm?
Then you drive potassium to where it came from.
Drive potassium back to where it came from. If you are a pascologist, you would realize that hyperkalemia management is not a rare question in MDC. Although I am telling you the arms, I'm not saying when you go there, go and say, drive potassium back to where it came from. This is to help you answer, okay? What is your next arm of management? Yes?
Flush potassium out.
Flush potassium out of the body. Flush potassium out. What is your next line of management?
Then you prevent potassium from entering the body.
Prevent potassium from entering the body. So, on that note, Maulom, Queen,
Yes, doc.
which IV fluid would you use in managing the patient with tumor lysis syndrome?
You said they have, so you gave Ringer's lactate.
I believe cool.
Normal saline.
Why not Ringer's lactate?
Because there's Ringer's lactate has doc, I don't know.
No, you know. Am I giving you pressure? You know. Because Ringer's
Yes.
lactate has what? I'm giving you pressure.
It contains bicarbonate.
No, but the patient is
lactate.
go ahead.
Doc, I don't know how.
Ringer's lactate actually contains potassium.
Okay. And
So
they already have.
Exactly. They already have hyperkalemia. When we got here, that was why I drew attention to that. So prevent potassium from entering the body from outside. Do you see that?
Yes, doc.
So Ringer's lactate, although contains bicarbonate, would not be an ideal fluid because between the acidosis and then the potassium abnormality, the potassium will kill the child first. Now, Suma, go ahead. What other arm?
Hello, doc.
Yes, what other arm? I'm
Doc.
listening. Yes.
Hello?
Yes, I can hear you. Go ahead.
Doc, the question.
What other arm of... You are not done. What are the arms of hyperkalemia management? We are not done. What else?
Doc, these are the ones I remember.
Okay, Abina.
Okay, correct. And any pathology that would increase the potassium levels.
Correct any associated what? Condition, isn't it? Like what? Abna, like what? That will worsen the hyperkalemia. Like what? Yes.
Hold on, I'm coming.
Who will help note in one?
No, it's not there.
Oh, like metabolic acidosis.
Okay.
Like acidosis. That's why we give sodium bicarbonate at points.
But you see, I feel like it's not both ways. I feel like it's only hyperkalemia that can lead to that.
No, but acidosis can worsen it.
Okay. I had it in mind.
If you watch, the point is that let me end it and then explain something to you. An acute dialysis, isn't it? If all of these fails, acute dialysis. Please, the rest. Are you here? Tina, did you get a story?
Yes, please.
Okay, so can I clean?
Yes.
Okay. Listen, you see that your cells, there's the blood, okay? And then these are the various cells. Okay, these are your cells. And then this space is the interstitial space, isn't it? And you know that the blood space and then the interstitial space, they are all part of the extracellular compartment. So their electrolytes content is almost the same, isn't it?
Yes, sir.
Hello? Okay.
Hello. Yes.
Now you have
Yes,
a patient, with hyperkalemia. The body has this pump. If you remember the explanation to the paradoxical aciduria, it's the same thing. The body has this pump. This pump I have drawn is the hydrogen potassium pump. Whenever the body sees that there is that, the body has been programmed in such a way that there should be homeostasis. It regulates itself. If you know the food you eat, the meat you just chewed, the red meat, the number of acids in that meat, but you are still fine. You went to sleep and then you woke up to stretch. So it's because the body corrected itself. Now you have hyperkalemia, like that. What the body does is that to be able to help the system to correct the hyperkalemia on its own, because of there is a pump here, it takes in the potassium and brings out what? Hydrogen. So when you have hyperkalemia, you are forcing the body to actually throw hydrogen into the extracellular space. Do you see that? That's what you're essentially doing. That you think about it. Why do you think at a point or sodium bicarbonate is given to DKA sometimes? Patients with DKA. Do you know that? Did you know that sodium bicarbonate is given to patients with DKA?
Yeah, the last time you mentioned it.
No, but before I mentioned it, did you read it in textbooks?
Okay.
Who has read it in textbook before? Maulom.
So,
Have you read it in textbook before? The management of DKA. Sometimes.
sodium bicarbonate.
Yes.
No, please. Maybe
You've
I
not
have
read. You've forgotten. Okay. You just go and read and come. Good. So the reason is that you are trying to what? Decrease the you see, there is acidosis. There's actually acidosis in DKA. When you give this, you actually reduce the H plus, then you stop this mechanism from happening. So this is a symptom.
Okay, Doc.
It works in either ways. So when there is acidosis too, what happens? In order to correct that acid-base imbalance, because if it doesn't, the body will crumble down. It takes in the hydrogen and then bring out the potassium, just so that it can manage the acidosis or acidemia. Do you see that?
Yes, Doc.
Good. And so, looking at this, stabilizing the heart, what do you use? You use 10 mL of 10% calcium gluconate. 10 mL of 10% calcium gluconate. And remember the principle that actually you don't always stabilize the heart in hyperkalemia. You only do that when the potassium level is more than 6.5. Your result said it was more than 6.5. Or regardless of the potassium level, the patient is symptomatic of hyperkalemia. The patient has tachycardia and all those. Patient is symptomatic of hyperkalemia. Even regardless of the potassium level, you have to protect the heart. Or you did an ECG and the ECG showed you what? Findings of hyperkalemia, including, we say that for hyperkalemia, everyone on the ECG is affected. for hyperkalemia, everyone on the ECG is affected. And you know that the ECG is made up of what? The P wave, PR interval, KRS complex, T wave, ST segment. So on the P wave, the effect is that there will be a flattened or absent P wave, but usually it's flattened. Flattened or absent P wave. On the PR interval, there is a prolonged PR interval. Although some teachers say that there's a shortened, but it's actually prolonged PR interval. On the KRS complex, there is a wide KRS complex or a prolonged KRS duration. And also, the R wave is what? The R wave, this one, is what? Short. On the ST segment, there is an ST segment depression. And then for the T wave, there's a tall tented T wave. But among all these ECG findings I have listed, tall tented T waves, among these ECG findings I've listed, when you are asked about ECG findings of hyperkalemia, this is what you should mention first, although it has mentioned last because of how I taught it. Tall tented T waves. And if you're asked what else would you find, then you can start. There can be a flattened or absent P wave, a prolonged PR interval, a widened QRS complex, and a short R wave, and then the ST depression. Okay, there's also ST segment depression. Am I communicating?
Yes, Doc.
Yes.
Silent majority. Okay, all right. Debbie. Della,
Yes, Doc.
are you there?
Yes, please.
Don't be tired, eh?
Okay.
Don't be tired. It's a battlefield. Then the next one said drive potassium to where they came from. Now, potassium, the abode or the home of potassium is actually what? In cells, intracellularly. So drive potassium back to where it came from. It means that drive them back to cells. Drive them back into the cells. What do? You give insulin. Soluble insulin. The insulin works on the sodium potassium ATPase and then drives potassium back into cells. But you want to prevent the side effect of insulin, which is what? Hypoglycemia, by giving 50% dextrose in addition. So it's not like the sugar does something, no. Because when you are giving the patient insulin, you might cause hypoglycemia. That might even kill the patient. So you want to do this. Then nebulized salbutamol also drives potassium back to where they came from. Nebulized salbutamol.
Doc, please, I have a question.
Go ahead.
The 50% dextrose, is it the same as 50 mils of 5% dextrose?
No.
Because that's what I know. So it's
Listen,
rather 50% dextrose.
This thing, people, a lot of literature, some people even give 50 mils of 10% dextrose, just 10%.
Oh, okay.
So as usual, whenever a controversy occurs, we use up to date, isn't it? The world's most recognized. So we'll go and check it and get back and then update it on the page, okay? Is that okay?
Yes, please.
Okay, good. So then you flush potassium out by giving what? Potassium losing diuretics like furosemide. Prevent potassium from coming inside. What do? You prevent the patient from eating every potassium containing food. So stop potassium containing food. The patient is not going to eat banana, is not going to eat tomatoes, not going to eat coconut water and all those things. So stop potassium foods. Any drug that contains potassium, stop it. Stop potassium containing drug. So Maulon, you now understand why Ringer's lactate should not be given.
Yes, please.
Then correct any associated abnormality, especially when the bicarbonate is low. Correct any associated, especially when the bicarbonate is low, which you will see on the BUE creatinine. correct any abnormality that would what? Worsen the hyperkalemia. So when you do the BU creatinine, the bicarbonate is normal. It gives you an impression that this hyperkalemia, it's not like there is an acid-base balance which is worsening it. So that's why bicarbonate infusion is an optional thing. Do you understand? Once you see acidosis, you have to correct it. Do you understand?
Yes, sir.
Then one thing you can do to prevent potassium from coming inside is to give the chiazolate salts. Okay, they can also bind to potassium in the GIT, and then that would prevent potassium from coming in. Now, if you've done all these, and then the patient is still not responding, still has hyperkalemia, you may have to do dialysis. Okay, hemodialysis. Is that okay? So this was a chance for me to reiterate hyperkalemia management again. Those of you who have been with me for a while, you see that repetition is not something that is uncommon in this class. So that if you've forgotten, go back. So yes, and then I think that should be it. Now, if you go back to the question, I'm sorry, any questions? Any questions?
No, Doc.
Okay, now if you go back to the question is asking for state other two biochemical abnormalities and explain the reason behind these abnormalities. We've dealt with it, isn't it? Now, what is the corrected calcium? What is the corrected calcium? This is also another thing I should address. Now, whenever you request for calcium levels from the lab, whenever you request for calcium levels from the lab will give you two calciums, ionized calcium and then serum calcium. Ionized calcium, serum calcium. Please note that I didn't bring all the GMDC questions in, okay, to this mock. In the next mock, you'll see subsequent ones, okay?
Yes,
I
sir.
intentionally didn't do that. Okay, good. So when you see ionized calcium, so you see in the body, calcium is found, 99% of calcium is found in bone and in the enamel. 99% of body calcium is found in bone principally and in our teeth, the enamel. Only 1% is found in serum. And even in serum, some of them exist as free calcium. That's the ionized calcium, okay? Ionized calcium. So the serum calcium, the calcium in the serum, some of them exist as free, some of them are bound to albumin. It means that changes in albumin concentration can affect the value of the serum calcium. Once albumin is carrying some calcium, changes in the albumin concentration can what? Affect the serum calcium. That is why for labs with very high GCS, when they quote the serum calcium, they make you know the albumin level so that you know whether you want to correct it or you don't want to correct it. Do you understand?
Yeah.
Then some of the calcium is bound to phosphates. So it exists as what? Phosphate salts. So it means that when you see a lab which has quoted total serum iron, what they are trying to tell you that the value they've quoted is actually the ionized calcium plus those which are bound to albumin plus those which are what? Complexed to other anions to form salt. Do you understand?
Yes, Doc.
Silent majority.
Yes.
So when you see ionized calcium, if in exam you see that they've given you ionized calcium, there is no need to correct anything. Don't go and say corrected. No. Ionized calcium is not total calcium. They are giving you what it is actually. Ionized calcium is calcium, which is what? Unbound. Ionized is free. Okay, so ionized or unbound calcium. Once you see ionized calcium, if the value is low, the patient has a hypocalcemia. If it is high, that is the true value. There's no need to correct it because ionized calcium is not affected by the changes in albumin, because by definition, ionized calcium is a free calcium. It is an unbound calcium. But if the value you had was total serum calcium, or they just quoted serum calcium, then you have to correct. You have to correct the calcium. Please, are you okay? So, how do you correct calcium? How do you correct calcium? Before we started this class, it was of great importance. The reason behind why I taught you how to learn. I said that there are some concepts which have to be memorized. Some have to be understood, and some have to be taught by you. You have to be able to teach somebody. Now, I'm going to give you a rule, and that rule, you are supposed to keep it in memory. There's nothing to understand about it. The rule is that for every 1 gram per liter decrease in albumin, calcium should rise by 0.02 millimole. It's like a law, like Cuvier law, like Boyle's law, like the law of Pythagoras. The square of the hypotenuse is equal to the addition of the square of the adjacent and then the opposite side. Why would you want to go and ask the man why? Pythagoras, please, why? It is not asked, it is a rule. So for every 1 gram per liter decrease in serum albumin, calcium should rise by 0.02 millimoles. Repeat after me. Go. Read what I've written.
For
For
every
every 1 gram per liter decrease in albumin, calcium should rise by 0.02 millimoles.
Yes. So it means that if they quote, let's say calcium as say 1.8 millimoles, and then they tell you that the normal range is 2.2 to 2.6. You can't go and say, hey, 1.1, 1.8 and 2.2, so it is low. No, you have to go and check the albumin level. You have to go and check the albumin level. If the albumin level is normal, let's say the albumin is 40 grams per liter, and you check that the range is 35 to 55. Do you think albumin has reduced? If you check, albumin has not reduced, isn't it?
Yeah.
So because albumin has not reduced, this calcium you are seeing is a true one, because the rule says that for every 1 gram per liter reduction in albumin, calcium should rise. It means that if albumin has not reduced, calcium should not rise. So in a patient who has a normal albumin level, whatever you are seeing for the total serum calcium is the true reflection. Is that okay?
Yes, though.
Now, note the unit that has been quoted. If you go to the question, please, I want you to note that 35 gram per deciliter, sorry, per liter, is the same as 3.5 grams per deciliter, okay? 40 grams, so the difference has to do with the unit that is used. When you see 40 grams per liter, it is the same as 4.0 grams per deciliter, okay?
Yes,
Okay.
So it means that if the examiner gave you the albumin in, say, they tell the albumin is 2.3 grams per deciliter, in your head, you know that this is the same as 23 grams per liter. If they gave it to you as 4.3 grams per deciliter, in your head, you know that it's the same as 43 grams per liter. If they gave it to you as 100 grams per liter, in your head, you know that it's the same as 10 points. Do you see that?
Yes, sir.
Yo. Now listen. Let's go to the question. How long?
Yes, Doc.
Queen, are you here?
Yeah.
Good. So watch the calcium level. If you watch the calcium level here, you will see that it is 1.8, and then the reference range they are giving you is 2.2 to 2.6. With a she, the patient has hypocalcemia. No, this is not ionized calcium. It is serum calcium. So go and look at albumin. You go and look at albumin. Indeed, albumin has reduced. Do you see that?
Yes, Doc.
So this lab can be recoded as, you see that the unit is in gram per deciliter. It can be recoded as albumin is actually 30 gram per liter with a reference range of 35 to 55 gram per liter. Do you see that?
Yes, yes.
Very good. So by how many grams has albumin decreased? By 5 grams.
Mm.
Do you see that? Because the lower limit is actually 35. Do you see that?
Yes,
So the albumin has decreased by 5 grams. Tina,
Yes, please.
you are following, right?
Yes, please.
Blessing. Blessing.
Doc, I'm following.
Yo. And now, within your era, no. Anyways, that is fine. Good. So, if you use this rule, for every 1 gram per liter decrease in albumin, calcium should increase by 0.02. Albumin has decreased by 5 grams. So if every 1 gram will increase by 0.02, it means that 5 grams would increase by what? 5 times 0.02. And this is the same as what? 0.10 millimoles. Do you see that?
yes, Doc.
So the corrected calcium then, now that you've corrected it, so the corrected calcium then will be what the lab is reporting plus what you've corrected, what I have corrected. Class, go. The corrected calcium is equal to what? Go. Read it.
What the lab is.
Plus what I've corrected. Again.
The lab value plus
What I have corrected. So the lab says it is what? 1.8. What I've corrected is what? 0.1. So 1.8 plus 0.1 is the same as 1.9, which is still less than 2.2 to 2.6. And so the patient is what? Truly hypocalcemic. So for this patient, the corrected calcium level using 35 as our reference, okay? We want him to get here, okay? The lower limit is actually what? 1.9. Do you see that?
Yes, Doc.
No questions. Excellent. What could have been done to prevent the diagnosis above? We've mentioned that. How would you manage this patient? We've mentioned that. Okay, so how many had 5/5? Okay, how about 4/5? How about 3/5?
Sorry,
What and what did you? What and what made you have the 2?
I could get the corrected calcium and then the diagnosis and also some parts of the question too.
Okay. But you couldn't manage the child then?
No, me dream when I weave.
And I saw some you feel. Now time as not mean you feel. Please, any questions?
No, doc.
Are you tired?